Hello everybody, Dr. Gavin Gardner here with another short video where I take a topic and cut it up into bite-sized chunks and feed it to you with a teaspoon. Today's primary objective is to discuss P's and compartments. What kind of P's, you ask? Well, we're not talking about Del Monte or Green Giant. Nope. Today's topic is much tastier. In this short video, we're going to discuss the P's of compartment syndrome. As you probably know, the muscle groups of our limbs are divided into sections, or compartments, formed by strong, unyielding fascial membranes. If an injury occurs, typically from a fracture, then there can be swelling within that compartment. And because that fascial membrane is unyielding, there's nowhere for that pressure to go. And subsequently, blood vessels and nerves can be compromised. To treat this, the surgeons will take the patient to the operating room where they do a fasciotomy to release the pressure within that compartment. So, fractures make up about 75% of the cases of acute compartment syndrome, but there are multiple other causes. Direct trauma without a fracture can even cause compartment syndrome, so it's got to always be on your radar. Burns can also be a cause of compartment syndrome, particularly circumferential burns. So can constriction from a cast that's too tight, or penetrating trauma like a gunshot wound. One that will sneak up on you is high pressure injection injuries. These are patients who've had a high pressure injection from a paint gun or a lubrication gun. Oftentimes these seem mild at first, but severe symptoms can develop over time. Vascular injuries are also another potential cause. And you should also watch out for patients with bleeding diatheses like hemophilia. Animal bites are on this list, as well as stings and envenomations. However, that's controversial. A lot of people would say that you just need more antivenom rather than a fasciotomy for a snake bite. Now, I know what you're saying. Get on with the P's already. But just hold your horses. First, I have a public safety announcement. Did you know that peas boiled with onions and spiced with cinnamon is considered a powerful aphrodisiac? First, gross. Second of all, be careful. If your date fixes you peas with cinnamon and onions, I'm just saying, that's my safety tip. You're welcome. Traditionally, we think of the 5 P's of compartment syndrome: pain, poikilothermia, pallor, paresthesias, and pulselessness. But commonly, you'll see a 6th one thrown in there as well: paralysis. The first P, pain, really shouldn't be a surprise, but it's usually described as pain that's out of proportion to the exam. In other words, they're in a lot more pain than you would think that they should be. Poikilothermia is defined as an inability to maintain a temperature that's independent of the ambient temperature around you. Now, they could have just said cool to the touch, but that wouldn't have started with P, would it? Pallor just means that the limb is pale in color. This is a pretty good example because it's kind of subtle. You can tell that the foot on the right is a little bit more pale than the foot on the left. The next P is paresthesias. It's actually not all that uncommon for patients with compartment syndrome to present with their primary complaint being numbness after the injury. Pulselessness is one of the last things to happen in compartment syndrome, but for sure, it's going to be the first thing that the orthopedists ask you about on the phone. But don't let the fact that they have pulses lead you away from the diagnosis of compartment syndrome. It happens late in the disease process. The last one is paralysis. Now, this isn't on everybody's list, but I can tell you that I've seen patients with compartment syndrome who also had associated paralysis. So let's say that you have a patient that you suspect has compartment syndrome. The next step is to measure their compartment pressure. There are a few devices for this, but the most commonly used one is the Stryker. A normal compartment pressure is from 0 to 8, but we really don't get excited until they start to get around 20. Those patients don't need to go to surgery, but they need additional monitoring. Some would recommend that if the pressure is greater than 30, that those patients need to go to surgery for fasciotomy. Perhaps a more accurate way to define who needs surgery and who doesn't is using the delta pressure. The delta pressure is obtained by taking the diastolic blood pressure and subtracting the measurement you got for the compartment pressure. If that difference is less than 30, that patient likely needs to go to surgery. So then, diastolic blood pressure and compartment pressure go together for the diagnosis of compartment syndrome just like peas and carrots. So now you know all about compartment syndrome and the peas that go along with it. Maybe next time we can talk about why celery should be eradicated from the earth, because as far as I'm concerned, it's just a weed. I hope that you found this short video useful, and it was my pleasure bringing you this educational material.